morning, everyone. I hope you're all doing well. Firstly, for those who are not familiar with me, my name is Diane Masawe, and I will be your host for the next 90 minutes as we delve into this, really interesting topical question around intellectual property access and the COVID vaccines, and what this means for us and for our communities. Before we start, I'd like to let you know that we are recording this session, and I hope that's okay. And the reason why we're recording is just so that we don't miss out anything, that we're able to capture all the discussions that we're going to be having in the next 90 minutes, which will then inform the report. I hope that's okay. And then also, before we start, can I ask that if we're not speaking, that we have our mics on mute. If we want to speak, we can then unmute or raise our hands. But also the chat box is open. So if anybody wants to drop a message either to myself, the host, or even to the group, please feel free to do that. Before we start, I would like to ask if we can all go around and just introduce ourselves. The introduction can be, your name or the given name you'd like to be referred to, for the next 90 minutes in this discussion. If you could also let us know which organization or, which community or sector you are coming from. Can I then also ask, and some of the admin things I will also be putting in the chats, is that at the end of the discussion, the session, and early next year, you'll be getting certificates of participation and attendance. So if I could also ask if you could then type your names, your full names, or the names as you would like to appear on that certificate in the chat, so that we don't get any spelling errors, and we get the names that you'd like to be referred to. Anybody can start.
Hi, how are you? It's Rose here. Sorry. Can anybody hear me?
Yes, we can.
Okay. Apparently, for me, I just want to ask, because I have no idea about this meeting. I was just sent the link, and I just saw the link last night from Wayne Helfrich. So I don't see him on the group, but I really don't know what's actually happening here because I thought maybe I'm in a wrong platform, but maybe I can get the clarity of what's happening here. Thanks.
Okay, morning, Rose. You are not on the wrong platform. I think you've worked in the PWID space, people who inject drugs programs, or is it in the sex work programs?
Apparently, I'm a PR counselor, the city of Tshwane. I'm under the program COVID.
Okay, so Rose, so you are part of a discussion that is looking at intellectual property access and COVID-19 vaccines, and what this means for the different communities you're coming from. So Wayne was invited as somebody who has worked in programs with key populations.
The group of the city of Tshwane.
Okay, so maybe, yes. Okay, so, and I think, maybe
you never discussed with me anything to Wayne
of flow.
In that case.
Okay.
Sorry?
Do I go on? Okay, my name is Barrister Mrs. Mma Obonna. I am a branch head in health research ethics from Federal Ministry of Health in Nigeria. I am a legal practitioner. That's a lawyer working in the Federal Ministry of Health. I'm interested to be part of the meeting based on intellectual property and COVID-19, being the fact that my country is part of a WTO Act that has been domesticated in my country. Hence my interest. Thank you.
Good morning, everyone. My name is Anna Machenda Wafa, and I'm with the African Alliance. I'm the lead coordinator. Thank you so much, Diane. Thank you so much, Fatima, for making this happen. Thank you.
Morning, colleagues, comrades. It's Pumzile Mashishi from FEDUSA, also SANAC labor representative, you know, in South Africa. Thank you.
Tumelang, can everybody hear me? Hi, my name is Palesa Komane. I'm from the organization Show Me Your Number, and I'm the Operations and Communications Manager, and we're dealing with the Human Rights Program, as well as advocacy, TB in the Mines, and adolescent girls and young women. Thank you so much.
Yes, hello. Good morning, everybody. Another Nigerian in the house. My name is Jimo Hamzat. I'm interested in biomedical ethics. I'm a lecturer in a Nigerian university. Nice to be here. Thanks.
Morning, colleagues. This is Temeka Makungo from Show Me Your Number. I am the M&E manager. Thank you.
First.
Good morning, colleagues. My name is Kanyisi Lengema. I'm working for Show Me Your Number organization, KZN IPO support officer. Thank you.
Good morning, colleagues. Hello.
Go ahead, colleague.
Oh, okay. My name is Khabe Mujanaha. I'm with an organization called Blighter Projects. Our core business is youth development, as well as advocacy and awareness for comprehensive sexuality, as well as sexual and reproductive health rights. I'm also with the youth sector at SELEC. Thank you.
Morning, colleagues. My name is Monica Madika. I'm the IPO support officer for Show Me Your Number, working on human rights program. Thank you.
Good morning. My name is Rosemary Mboro. I am working with Waki Health, which is an Africa regional advocacy organization. I'm also a member of the VAG, which is the Vaccine Advocacy Resource Group. We are very much, as Waki Health, interested in issues around equitable access to health services, and in this case, equitable access to COVID-19 technologies. It's a great pleasure to be here.
Hi, everyone. My name is Unati. I work for Just Detention International South Africa, which is a health and human rights organization that seeks to end sexual violence in all places of detention, but we've mainly been working in South Africa's prisons. And I am the program officer. I'm really excited to be here. Thank you for hosting this.
Morning, everyone. My name is Tabo Majuja from Show Me Your Number. Thank you.
Morning, colleagues. My name is Mabala. I'm also from Show Me Your Number, and we have a keen interest in this to learn and to contribute to the action.
Good morning. Is that everyone? Okay. I think for people who've just joined, thank you for joining us in this discussion that is on intellectual property, access, and COVID-19 vaccines. I think before we start, I'll ask Tian Johnson, the Director for African Alliance, just to say a few words, and then I'll introduce Fatima Hassan, and then we will delve into the presentation, which will then follow up with the session on question and answers and any issues of clarity. Tian, over to you.
Great. Hi. Thanks, Diane. Welcome, everybody. Just to say a quick word of welcome to everyone. Thank you for joining us this morning. We're looking forward to an exciting session with support and in partnership from our colleagues at the Health Justice Initiative, who have taken their time and have come on this platform to share their expertise around IP and what IP means for us as civil society in South Africa. And there's certainly lessons to be learned that could be applied regionally. So thank you again for your time and your dedication to the work that we collectively do. This particular special COVID-19 conversation is made possible with the support from the Norwegian People Aid. So thank you again, everyone. And thank you, Diane, for hosting, and welcome, Fatima.
Thank you, Tian. I will hand over to Fatima Hassan, who is the head at the Health Justice Initiative, who will be leading us in this presentation. So I think if you've got questions, please either jot them in the chat box or just hold on to it, because then after the presentation, we'll have a good session in terms of question and answers and any issues of clarity. So the agenda, we've done the introductions, we'll do the presentation and then the question and answer. Thank you, Fatima, over to you.
Thank you, Diane, and thank you, Tian and colleagues at the African Alliance and WAG, and also thanks to all of you for making time the day before public holiday. I just want to say two things at the outset, and I'm not sure if Chua is sharing the screen, the slides, Chua. Okay, so can you just confirm that you can all see the slides, Diane?
Yes, we can.
Okay, great. So the first thing I want you to know is that this is going to be a series of conversations, so please don't get scared about the word intellectual property. We will share our contact details at the end of the presentation, so if you're still confused or if you still want to ask questions, you're welcome to email us. My colleague Althea is also on this call from the Health Justice Initiative. You can also look at our website. There's a lot of information, and in the presentation we give you some links to other readings as well as to other organizations that could be quite useful for the work. So I'm Fatima Hassan. I'm the head of the newly established Health Justice Initiative, and I've worked with some of you, and pleasure to meet the others who I haven't, on HIV and AIDS and a lot of activism around health rights. So the second thing is that this presentation is very South Africa focused, so apologies to anybody who's not from South Africa, because that was the brief given to us. So next slide. Okay, so I thought we would just put things in context, because when people try and understand why we're focusing on intellectual property and also on the issue of patents, it obviously exists within a particular context. So we now know that we've had in our continent more than 2.3 million cases of confirmed COVID. We've had 53,000 deaths in the continent. This is probably underreported, but these are the official stats. In South Africa in particular, we've got an ongoing second wave. And I think all the fault lines of our public and private healthcare system, what we call a dual healthcare system or a two-tiered healthcare system, is coming to the fore. The concerning thing as we go into the Christmas holidays and end of the year break is that we have quite a high fatality rate compared to other parts of the world. It's about 2.7%. And in some provinces, we're really quite sadly seeing the total collapse of our health systems, particularly in the Eastern Cape. And I'm sure you all saw the President's address last night about some of the non-pharmaceutical interventions and measures including curfews and restrictions and lockdowns for some parts of the country. The second issue that's emerging in this crisis is that globally, government relief for the impact of COVID and the impact of lockdowns is actually insufficient. There's massive job losses in many parts of the world, a real hunger crisis, and also ill health, as well as what we're all quite concerned about in the healthcare sector, the severe interruption of prevention and treatment services, especially for HIV/AIDS, for people who use drugs, for sex workers, for access to sexual and reproductive health rights. So testing is on the decline. Commencement of new treatment regimens is also on the decline because of the lockdown and the interruptions. In terms of vulnerable groups and communities, I think you all know this better than I do because you're working on the ground and you're working directly with vulnerable groups, but there's obviously a disproportionate impact, especially for women, and in particular for workers who are not regarded as workers. So for example, their work is criminalized. In particular here, I'm talking about sex workers. So the impact on them has been quite severe because they've been precluded from accessing state relief and social security for job loss. So far, within this global context of quite a devastating, I think, global pandemic and the impact that it's had on all of us, there are no real sustainable long-term treatment options. There is dexamethasone for if you're severely sick, if you're hospitalized and you're on a ventilator, but that's about it. And that's why there's been such accelerated emphasis and research on a vaccine. And what we've seen is this huge investment in vaccine clinical trials and research, where there are actually now vaccine options available. And so for now, we can focus on vaccines. It may be in a few months' time, there'll be some treatment options, and then our focus will be on that as well. So since January 2020, we've never seen this in any other pandemic before. We certainly haven't seen it in HIV. There's over 200 vaccine candidates, various stages of clinical investigation. There's at least 12 in phase 3 trials, which is quite significant. However, if you want to create herd immunity, it means that two things need to happen. We need to have high vaccination coverage. So at least 70 to 80% of any country's population would have to be vaccinated, would have to agree to be vaccinated. And you'd also need high efficacy of the vaccine. So the higher the efficacy of the vaccine is, then the lower population coverage that you'd need. We've now had emergency use authorization approvals in the UK, and so you've seen all the media reports about Pfizer there. The US have started as well. The FDA has just given them emergency use approval, and then Russia, China, and Cuba. There's various developments, but obviously this, things are moving so fast. The goalposts are moving so fast as well that we're trying to get more details about the status of regulatory approval of those vaccines. And in one case, Russia is potentially going to be partnering with one of these so-called Western pharmaceutical companies to look at possibly injecting people with a combination of their vaccine and the Pfizer one. But alongside all of this, I'm sure you all know and you've seen there's an anti-vaccine movement spreading, which I think is going to also make our work a bit more difficult as we go forward. So, I just wanted to spend a bit more time on the context so that you'd understand why we have such a concern and a focus on vaccines. Next slide, please. So there's two things you need to know about as activists in relation to the vaccine movement. Because of the concerns that started emerging in the beginning of the pandemic, where even though global leaders had said that there should be global solidarity and that nobody would profit and any scientific innovations for dealing with COVID would benefit the whole world, we all knew that that would not materialize because we've all had experience in HIV/AIDS and we know how these things play out in the real world. So the People's Vaccine was born, early on. The People's Vaccine campaign was born early on in this year. And the notion behind the People's Vaccine is that everyone everywhere who needs it must get a safe and effective vaccine. preferably at cost or preferably for free. So at the moment, we have a situation, what we call vaccine apartheid. Some countries are providing vaccines already to their citizens for free, and some countries we're probably going to have to pay for it or have a user fee if you can access limited supplies. But the people's vaccine is not just about the vaccine, you know, in itself. It's also about any diagnostic tool, any treatment, and also the vaccines not available to everyone everywhere at the point of delivery. And, you know, I've provided the links for the people's vaccine, as well as something called Free the Vaccine. And these are two organizations that are quite useful as you do your work in campaigning, you know, for equitable access to a vaccine going forward. Next slide, please. So you may be wondering, you know, to put it frankly, like, what the hell is going on? Things are moving so fast within, you know, 9 months. So let me just give you some background. So ordinarily, the way in which a medicine would come to market or a vaccine would come to market would take quite long, right? There's many steps. There's the investment, then there's the research, then there's the patent seeking, then there's a regulatory approval, then you've got to deal with supply issues, delivery issues, and access. But with COVID-19, all of these steps have actually been compressed, and that's why it's very difficult to actually, you know, get a hold of what is actually going on. But I really think as community workers or as activists or as health justice, you know, campaigners, we need to be looking at, we can't look at everything, and we obviously don't have the human resources to do everything, but we can look at the issues that are highlighted in purple, the patterns, the regulatory issues, and the access issues. Next. Next slide. Next slide, please, Chiwa.
Sorry, it's just frozen quickly. Just want to get there.
Okay. Well, let me continue while you figure out the technology, and we will be sharing the slides with everybody after the call. So don't worry. You know, you don't have to take, you know, very detailed notes.
It should be up there
okay.
now. Understanding
it's up
IP.
There?
Yeah.
Great. So for those of you who prefer to listen to a podcast to understand intellectual property and patents, you know, we obviously would refer you to the podcast series that we did earlier this year. It's 4 episodes, and the first one discusses intellectual property. So you're welcome to have a listen to that as well. So now let's deal with what people think is a difficult issue, but it's actually quite a simple issue. And I'm going to try and take you through it so that you can at least have a better understanding of when we talk about intellectual property and when we challenge government on their policy around intellectual property, then, you know, you have a better context of what we're trying to refer to. So somebody's mic is not on mute. Maybe they could mute it. It'd be great, thanks. So what is intellectual property? It refers to the creations of the mind. So you invent something, or you write a book, or you know, design an artistic work, or you create a symbol, which is normally used in commerce. And so if you innovate and you do something that is totally new and innovative and you've invented something, your invention would normally be protected through what's called a patent, or you can have something copyrighted, or you could get trademark protection. And this enables people to earn recognition or financial benefit from what they invent or create to reward through innovation. So a patent is something which is an exclusive right that is granted for, somebody seems to be deleting the slide with the red marker, so I'm really not sure what's going on. But a patent is basically provides the patent owner with the right to decide how the invention can be used by others. And in exchange for this right, the patent owner makes technical information about the invention publicly available in the published patent document. Now that's, you know, taken from WIPO, which is the World Intellectual Property Organization. Trade secrets are IP rights on confidential information which may be sold or licensed. And so you can't disclose trade secrets or else you'll be guilty of an offense. And we've just provided the definition of a copyright there. So the important thing for our work in health access and medicine access is obviously the issue of the patent. And we'll come later to the issue of how trade secrets on pharmaceutical confidential commercial information is impacting our ability to access medicines later. Next slide, please. Okay, so now when we talk about TRIPS, I'm sure you've heard this word TRIPS being bandied around. So what does TRIPS mean? So TRIPS is basically just a shorter name for the Agreement on Trade-Related Aspects of Intellectual Property Rights. And so TRIPS basically sets the standards for how countries around the world have to protect intellectual property, including patents. And unfortunately, it's treated the same as like a car or a handbag. And so TRIPS actually governs the intellectual property protection of medicines as well. It came into effect in 1995. It's binding on all members of the World Trade Organization. South Africa is a member state of the WTO. There's about 150 countries. And by being part of the WTO, you obviously get other so-called benefits around trading with other countries who are member states as well. And by being part of it, you agree to certain common standards in a way in which you prepare your own local patent laws. But there's certain things that you have to agree in order to be a member of the WTO and in order then to give effect to TRIPS. So you have to give patents for a minimum of 20 years. So the patent holder has exclusive rights to that invention or innovation for 20 years. You have to give patents for both products and the processes to develop that product. And also pharmaceutical test data has to be protected against unfair commercial use. But what deserves to be patented is left for each country to determine. So presumably South Africa can decide some things are not patentable and some things are. And we have always argued for the last 25 years that in respect of access to life-saving medicines, they should not be patented, because they actually save lives and they are very different from a commercial product and they shouldn't be commodified. So what happens is when countries implement the TRIPS agreement, standards around intellectual property, it then means that only one company can make that product for 20 years. It limits competition, it limits manufacturing, and that in turn then affects access to medicine. So take a cancer medicine, for example. If a company has a patent on it for 20 years, then for 20 years, no other company can make that medicine, and the technology is not shared. So by the time a generic version comes onto the market, you're looking at 25, 30 years later. And that in itself fuels a medicine access problem. So with that in mind, in 2001, what happened was people said, you can't have these rules in a public health crisis. And you'll remember 2001 was also after 9/11, when people needed urgent supplies to deal with the anthrax scare, right? So at the annual meeting of all these ministers and member states of the WTO in Doha, in Qatar, all of the member states agreed that in order to redress those imbalances, that they would adopt what's called the Doha Declaration. So I hope now you understand where this notion of the Doha Declaration has actually come from. And the Doha Declaration says that countries can use what's called the TRIPS safeguards or flexibilities to issue compulsory licenses or to import the same drug from another country if it's cheaper. And you remember that a lot of people were trying to import generic versions that were being made in India. India is regarded as a generic pharmacy of the world, so that we wouldn't have to pay high prices for brand name ARVs and for cancer and other medicines. So now, you know where the word TRIPS comes from. You know what the WTO's role is, and you also know how the Doha Declaration came about. And obviously I'm simplifying this. There's lots of academic articles that if you're interested, you can read through. But now we come to something called TRIPS Plus, because obviously you adopt the Doha Declaration, you have all these safeguards. The pharmaceutical industry, wealthy governments, lobbyists, are not too excited about the fact that governments can basically overrule patents in a public health crisis. So what often happens is that countries such as South Africa or Nigeria or other middle income or low income countries will be asked or coerced into keeping or passing what's called TRIPS Plus provisions. So these are laws that are in addition to what TRIPS actually requires. In South Africa, we call our laws TRIPS Plus because we adopted that during the apartheid regime, because the apartheid regime was deferential to some of these wealthier countries' interests. So what has since happened is that even though we have a new democracy, bilateral trade pressure often influences countries from not fixing those TRIPS laws or from not, actually having a more flexible patent regime. And this has been going on in South Africa for the past 25 years. It started with Minister Nkosazana Zuma trying to change this particular regime. And you'll remember that during the AIDS crisis, the pharmaceutical industry sued the Mandela administration and the minister because of the desire of the South African government to actually make use of measures such as compulsory licensing and parallel imports. And so this is something which is part of what's called the Fix the Patents Law campaign, of which MSF and Section 27 and a number of organizations are actually part of, and they're leading on that. So when we call for the patent laws to be fixed, this is what we mean. It's that South Africa's TRIPS, South Africa's patent laws has TRIPS Plus provisions. We have too much protection when we actually don't need that. So, there's a certain irony when we'll come later in the presentation to what we're saying in Geneva at the moment for COVID, but what we are not doing in South Africa locally. Next slide, please. So the next question is, how do patent monopolies work? And, obviously, what is a monopoly? So if I'm the only person that can make this pen, for example, and I have a patent on it and nobody else can make it for 20 years, and I don't give you permission, or I don't give Diane permission and Chiwa permission, or 2 or 3 people permission to make this pen, then basically I exercise a monopoly. I have a total monopoly on manufacturing this pen, selling this pen, and making a profit on it. Because as a patent holder, I can also determine the price. Oligopolies is where you just have, multiple, a handful of suppliers. And so they are the only ones that can make it. Myself, Chiwa, Diane are the only ones that can make it. We make a lot of profit. It limits the number of companies that can make it or distribute a generic equivalent. And that's what's happening with medicines in relation to patent protection. The other issue that has emerged in the last few years around patent protection, and particularly we're seeing this with cancer medicines in the US and we saw it with HIV AIDS medicines, is that I will say that I have a patent on this, and then 18 years down the line, because I know my patent is about to expire in 20 years' time, I will have a click lid instead of having it like this. So I will say, well, that's a new innovation. You don't have to take the lid off and on anymore, and therefore I want another 20-year patent. And so that's what we call evergreening. You just try and keep on having your patent protection forever and ever and ever, and for it continuing, because then you can make a lot of profit. The other issue we're dealing with is data exclusivity. So what some pharmaceutical companies have realized is that there are more community groups and activists that are challenging patent protection and the granting of patents. So what they will do is say that we have the right to data exclusivity, and that prevents competition. So that even when a medicine is not protected by a patent, then the pharmaceutical company will still have a monopoly around the data that it's producing through a clinical trial or a research trial, etc. And then it can still charge the prices that it wants. So this basically means that the monopoly that is held by a patent holder which is usually by pharmaceutical corporations and companies, and a lot of them have their head offices in the US and the UK and in other parts of the EU. And coupled with the lack of competition means that high drug prices can be charged for life-saving medicines, like they were, as you all know, for ARVs in the early years of the epidemic. Next slide, please. So I've just basically copied some images from MSF because I think they really explain this, in a remarkable way. It's so simple and it's easy to understand. So when we say you have market exclusivity, what does that have to do with health rights and medicine access? So what we're seeing is basically four things. That the way in which the patent systems are designed for protecting drug innovation and invention and patent rights is that it can be abused to limit market competition. It can be abused through evergreening. It can be abused by refusing to grant generic manufacturers permission to make the same version of that drug. And so that, in a sense, then blocks affordable alternatives. So if I'm the only one making the spin and I don't allow anybody else to, I'm blocking your opportunity to have an affordable version of the spin through a generic company that can produce a safe and effective version of it. And so what we're seeing with this whole drug development industry is that it's really not about saving lives and improving health. It's all about trying to leverage the most amount of profit and to increase shareholder value. And we've certainly seen in this COVID year already the profit and the stocks, the stock values of Pfizer and Johnson & Johnson and a number of these AstraZeneca have actually all shot up in a global pandemic. So I think that tries to explain a bit of the ironic situation that we're dealing with. Next slide, please. So I'm sure many of you have friends who work in the pharmaceutical industry, who work for the private sector. You'll read a lot of newspaper articles and op-eds and listen to radio shows where the pharma, which is short for the pharmaceutical industry, will tell you the following things. They'll say no, and this is what has happened this year. Intellectual property is not a barrier to access to medicines. That private investment, that private capital should be rewarded for innovation. They'll tell you that they've given a few charity, voluntary bilateral agreements at low prices, and those are sufficient, that you don't need multiple suppliers. They'll tell you that TRIPS as it stands is flexible, that it doesn't need to change, that the WTO is a perfect instrument for regulating international trade. We'll come to COVAX, but to put it simply, they'll say that COVAX, which is this new voluntary pooling mechanism to try and secure vaccine access for the whole world, that's sufficient. So they don't have to give more licenses. Government shouldn't issue compulsory licenses. We can all get our vaccines through COVAX. They'll tell you that donations are sufficient. We had that in the ARV years, where for MTCT, Boehringer Ingelheim decided to donate nevirapine, and they're like, well, we've donated nevirapine, so we don't have to do anything else. And also they will start peddling these myths, which are falsehoods, which are not true, which is not based on evidence, that Africa cannot manufacture safe and effective products. So how do we, respond in our dinner conversations, in these radio shows, in these meetings, to these kinds of arguments? Next slide, please. So there's a few arguments that we've been making for the last 25 years, and it's nothing new with COVID. And our response to those kind of arguments by the pharmaceutical industry and wealthier countries is always the following: that access to life-saving medicines can't only be based on charity and benevolence. We need enforceable undertakings, and we need more transparency. I mean, the example of COVID, when we talked about the accelerated vaccine research that has happened this year, where before even the end of December, for a pandemic that started in January, we already, vaccinating parts of the UK and the US, is that billions of money from the public have actually been spent on vaccine research for COVID-19, and all the details are, on the websites of all these organizations. But we're looking at, a couple of $1 billion of public money that has actually gone into vaccine research. And so it's not true that people spend money from their own private pocket, that the drug companies only spend their money to research a vaccine or any other medical product. The third response that we always have is that voluntary licenses are limited, even if they're helpful. So you can give 2 voluntary licenses, that's not going to be enough to make sure that there's vaccine dosages for the whole world. Because, you know, if you're the brand name company and you give 2 voluntary licenses, 3 companies cannot sort out the world's global access problems. The fourth is that we believe that COVAX has several limitations, and again, I will come and explain that later in the presentation. The worst situation that we're in, when I talked earlier about vaccine apartheid, is that rich countries have pre-bought supplies of vaccines through what we call advanced purchase agreements. And they've done that in a bilateral, in a global pandemic, between them and the drug companies. So they went to multiple drug companies and hedged their bets on multiple potential vaccine candidates and pre-purchased millions of dosages for their countries first, right? The next is that when people say TRIPS is easy to use and you can use the DAR declaration, it's very flexible, it's actually not. It's very difficult to use in practice. Most developing countries have not used it. There's only been one invocation of trying to use the DAR declaration. And that's coupled with the problem that we have domestically in South Africa, where we haven't fixed our patent laws as yet. There's some movement currently in Parliament, but we've been very fast to pass laws about roast chicken and open-toe shoes and beaches and curfews and alcohol and cigarettes, but we actually haven't passed the law that would really make a difference for most people right now, which is to fix the patent laws. Because if you fix the patent laws in South Africa, we would be able to oppose a patent being granted before it's granted, and our government would also be able to make easier use of compulsory licenses. And at the stage we're in now, on 15 December, if the president doesn't actually commit to issuing a compulsory license because the drug companies refuse to cooperate and we actually can't get access to the things that we need to potentially take us out of this pandemic, then I really don't know when we'll ever fix these patent laws and when they'll ever be beneficial for us. And then the last thing is that we've shown time and time again, in the Ebola crisis, in many other crises in Africa, that actually African companies and African governments can manufacture in a safe and effective way. And this manufacturing capacity can be ramped up on the continent through proper investment and data sharing. But you'd have to give us the recipe so that we can actually make a safe and effective product. Next slide, please. So I know that we're supposed to be talking about intellectual property and how that affects us all, but the best and clearest example is how it relates to what's currently happening and why we need to address vaccine nationalism and what that has to do with intellectual property and patents. So when we're trying to access vaccines and trying to understand the impact of intellectual property on vaccine access, we have to also remember that it's more than just about patent monopolies and patent rights. We would also need access to what's called the background technologies, the different platforms for all the different vaccine products, the foreground technologies, the manufacturing know-how and clinical data, which sometimes is called the trade secrets. And you would also need the company to have to transfer the technology and the licensing permissions to you. So what's concerning around vaccine nationalism, and remember, vaccine nationalism means that when some countries were only worried about their own population, that they bought up dosages of vaccines for themselves and actually didn't worry about the rest of the world or don't care about the impact that's going to have on the rest of the world. And so that's what we call vaccine nationalism. You can call it neo-colonialism, but I think you get the gist of it. So recent reports by reputable organizations, including Human Rights Watch, Amnesty International, MSF, many organizations, public citizens, have written that rich countries have bought up more than half of the world's supply. And I'm sure you've seen this in the media this week. Some countries bought 3 times what they need. Some countries bought 5 times what they need, like Canada, and has now said, okay, well, we'll give the leftovers donations, which is not a sustainable way to deal with this crisis. And so how have they done that? They started bilateral negotiations months ago and entered into what, I've talked about earlier, the advanced purchase agreements. They've also, by doing that, have limited access to certain geographies. And some of the companies have decided what price they will charge for different geographies. So they've got a tiered pricing model. In some parts of the world, you'll pay more. In some parts of the world, you'll pay less. And they've also put limitations and restrictions on what we call the API, which is the active pharmaceutical ingredients. So it's going to be very difficult to be able to make a copy or a generic version of something with all of these restrictions and all of these bilateral agreements in place. So let's go to COVAX and the limitations. I'm sure you saw the president has now mentioned COVAX twice in his address. There's a lot of media articles and reports about South Africa missing the so-called deadline and the Solidarity Fund having to come in and step in, which is itself a problem which we can talk about separately, and having to make a donation into COVAX. And so COVAX is a voluntary pooling mechanism. The idea is that they asked drug companies and governments to come around the table and negotiate. And so what they've come up with is a tiered pricing model where there's different prices for lower income countries, middle income countries, and high income countries. For South Africa, that's regarded as a middle income country. We must pay for it ourselves. So that's what we call self-financing, whereas lower income countries will potentially get it for free if they can raise enough donations and enough funding for that. So alongside all these bilateral agreements, COVAX has been playing out. But the limitations are that not every drug company that's researching a vaccine or a treatment for COVID has actually joined the pool because it's voluntary. Not all governments have. The US, for example, is an omission. They created their own deadlines for when countries should respond, when countries should pay. There's no pricing transparency on why they've agreed to certain prices with certain companies. No pricing data has been shared by those drug companies. We've talked about this for the last few weeks. There's unclear governance frameworks, who elected who sits on these advisory groups. And what it does is that it relies a lot on volunteerism and it relies on charity for low-income countries. So if you're a government health minister, you're not sure because there's only 2 vaccines that have been approved for use in the UK and the US. Nothing's been approved for use as yet in South Africa. But everybody's buying up stock through bilateral agreements, or they're going into COVAX, or what do you do as a health minister? Where are you going to get your supplies, knowing that most of the dosages have already been bought up? So it's I wouldn't want to be a health minister. It's definitely very confusing. And so what we have with COVAX and the bilateral agreements we're seeing is that a number of the drug companies who are ahead in the vaccine research and who've got emergency use authorization or are quite advanced with getting authorization, and we believe that some companies are already submitting data to our regulator, SAPA. So it will be interesting to see which is the one we actually approve for use first in South Africa. But they are refusing to grant multiple non-exclusive licenses in a pandemic, which would be on reasonable terms, right? So despite the AU showing a lot of leadership and solidarity and talking about a Africa-wide roadmap for vaccine access and coverage, none of them have publicly as yet committed to what we call the TRIPS flexibilities, which is compulsory license, because I think they're hoping not to have a trade war, not to have a showdown with these wealthier countries and these pharmaceutical companies who exercise a lot of power and influence. They're relying too much on goodwill. And I think they're also trying to hedge their bets on COVAX, which is, why I think they've also asking for the TRIPS waiver. And then, in the Q&A, we can talk about the WHO CTAP, which is a technology pool that the WHO is trying to have, but which many companies are refusing to participate in. Next slide. So some of the questions in preparing for this webinar was, what is the TRIPS waiver request? So we've now explained to you what TRIPS is, how that fits into the COVID time of access to vaccines and how intellectual property can become a barrier to access to treatment in medicines and diagnostics. So, and why it's so difficult for countries to make use of those TRIPS flexibilities. So against that context, and a context of a devastation from a economic point of view, from a hunger point of view, from a joblessness point of view, and from collapsing health systems in many parts of Africa, what the South African government did, quite surprisingly, with the Indian government, and remember we're part of BRICS, was that they, in October, jointly asked, they went to the World Trade Organization and they said, can you please give us permission to not apply the required TRIPS provisions to vaccines, drugs, diagnostics, and other technologies for managing and treating COVID just for the duration of the pandemic until global herd immunity is achieved, right? And of course, as we all predicted, they were opposed. And they're being opposed by Brazil, by Australia, by the EU, the UK, the US, and Canada. And which is why you would have noticed in the last week, there were many advocacy calls being made for these countries to not block the waiver. And more developing countries who themselves are having severe, COVID-related crises in their home countries are now supporting this call by South Africa and India. So the irony is that our government has gone to Geneva and is really pioneering and really pushing for this waiver and asking for permission to not have to apply patents on things that could actually take us out of this pandemic, but domestically has not passed the patent amendments in the South African Parliament, right? So I think, watching the advocacy demands on the TRIPS waiver, which particularly MSF is leading, and there's a briefing document that they've done, which I've put the link in, is going to be quite important. And I think it's also critical that we support MSF globally in this request, because it could be a small game changer, at least for the next 12 to 18 months, in terms of us being able to access more, medical products that could actually help in the management and treatment of COVID. Next slide, please. So if you as an organization are asked to, make certain calls, if you are sitting at SANEC meetings, if you're sitting with governments, if you're sitting at any of these forums, I think there's a few things that we need civil society to support us on, right? So the first is to obviously support the call for a people's vaccine or a free, or to free the vaccine. The second is that HAI, we actually wrote to government in November, and we've asked for details of the country's access and equitable allocation plan. Because we are very concerned that in South Africa, we have a two-tiered healthcare system. We've got a public system and a private system. And in the early days of COVID, when people thought that dexamethasone and remdesivir could be the solution, we saw the private sector buying up lots of stock and quantities of that, and then only making it available to medical scheme patients or patients who were going to private hospitals. And we know that there is global shortages, there's lack of supplies, there isn't enough, we're going to have to ration as a country. So we've asked our government, how are you going to deal with this disparity in our healthcare system in South Africa? Because we're talking about global vaccine apartheid, but we also don't want a local apartheid where if I'm a medical scheme member, I get access first, but because Chiwa goes to Groote Schuur Hospital, she gets access last, right? So the idea of one country, one plan is that there has to be one vaccine access equitable allocation plan. But we've had an acknowledgement of response, but we haven't had a detailed response as yet. And what is happening is that the Disaster Management Center has said that this has got nothing to do with them. It's actually the Department of Health responsibility. So as we get feedback from government on this, we will obviously share that information with the sector. The third, so the call behind that is that there needs to be an equitable plan for access and allocation in South Africa. We're very concerned that if there's only 10% of the world's supply available for South Africa, or we can only get 10% of our population vaccinated, it can't be everybody in the private sector. That is not equity. That is not what the Constitution actually requires. It would be totally unfair. The third call is that everyone everywhere needs to have access to it. It doesn't help if South Africa has access to the vaccine, but people in Zimbabwe don't. And similarly, people in Brazil have it, but people in Argentina don't. And this is similar to the arguments we made in the time of HIV and AIDS. We need to, when you're meeting the diplomats and ambassadors of the following countries, you need to really tell them to not be interested in profiteering, not protect the patent monopolies of these drug companies, and to stop opposing the waiver. We obviously need pricing at cost, not at a profit, for a longer period of time, more transparency, no unilateral decisions. And then the most important, which is why, you know, the African Alliance and WAG and HI decided to partner on this initiative, was that there's very little community involvement. And if you want South Africans to buy into a vaccination rollout, which is unprecedented, I think the last time we did this as a country was for polio. If you want a national vaccination rollout and you want buy-in, then you actually have to give us details about what your plans are, what is happening, how to ensure that we build community trust, how do we make sure that with so much information and things moving so fast that people are not hesitant to take a vaccine. So for example, vaccine hesitancy means that I want to take the vaccine, but I'm kind of waiting around to figure out what's going on, which is very different from people who are part of the anti-vaccine movement. And obviously, you all would have seen what the Chief Justice said last week, and that has taken us 10 steps back in terms of trying to get people to be confident in a vaccine. And then finally, you know, if you don't treat everything coming out in terms of treating COVID in this pandemic as a global public good, then we're just going down the road of profiteering, and we won't be able to manage this pandemic. Next slide, please. And I'm almost coming to the end, so don't worry. Hope you're not bored as yet. So I just wanted to take you quickly through South Africa, the situation at the moment that we understand it. There's very little sharing of information and transparency. So we've had to put all this together through media reports, investigative journalists, and civil society activists. And WAG has been doing a lot of work on this as well to try and find out what is happening in South Africa. We now know that obviously there are 4 vaccine clinical trials in South Africa, which means that they are testing these vaccine products on our communities using our research institutions in our country. There's the AstraZeneca one, the Johnson & Johnson, Novavax, and the Pfizer one. The Pfizer product is the one that's currently being rolled out in the UK, and that just got emergency use authorization in the US. They started in New York this morning, actually administering that vaccine, right? Our government has spent some money on these vaccine trials because we wanted to be the lead in Africa in participating in clinical trials, and we wanted to support scientific innovation. We've also given about 250 million rands of public, so-called private money from the Solidarity Fund to COVAX. But the thing is that MSF has reported that the vaccine candidates that are currently being rolled out by these companies have actually benefited from billions of public funding, which is what I talked about earlier. And so that just gives you a sense of how much money these drug companies are actually benefiting from public investment. And you'll remember that Johnson & Johnson and AstraZeneca, 2 of those companies that are getting public money from other parts of the world, are actually being researched in South Africa. But in all 4 of those clinical trials, we will not be guaranteed access as South Africans. There are no enforceable guarantees that we will be able to benefit from that scientific research in a manner that's sustainable and in a manner that's affordable. And that for us is a huge, huge crisis and a problem. And that's why in the last 2 days, there have been calls on these companies. It's a global set of calls for campaigning and advocacy around them, you know, issuing multiple licenses, sharing the technology, and dropping the prices. We also been reading in media reports. It's very unclear. All of this stuff is happening in commercial secret language, so we don't know. We're none the wiser. But we need to ask our government, and we need to ask these private companies what is actually going on, because the lack of transparency is not going to help. So apparently there are agreements being negotiated. We don't think anything has yet been finalized. And it seems like 2 companies potentially could be manufacturing vaccines for the rest of the world, but not necessarily guaranteed for us. So BioVac may be making some vaccines, which may be going to other parts of the world, and Aspen may be making the Johnson & Johnson vaccine, but we haven't been told whether some will be for South Africa and the rest for the world, or whether everything just goes to the global north. And again, that is a huge problem, because it means our workers will be manufacturing the vaccines, but won't be able to have access to it. Next slide, please. I think the main point about what's happening around the AU negotiations and conversations is that yesterday we were in a webinar with our minister and the Africa CDC and some other African leaders. And basically they've accepted, which I think is a problem. They should not accept that we have to ration. They should actually issue compulsory license. But be that as it may, they've accepted that there's going to be limited supplies for the whole of Africa. They're trying to figure out a fair and ethical framework for how do you give limited supplies to the whole continent. And they've accepted that we're going to have to ration. And so I think this is where you, as community leaders, would actually come in. Because the AU is now going to decide who gets these limited supplies. They're going to decide what's an at-risk population, what's an at-risk community, what's a vulnerable group. And so the key question we're going to have to be asking for all parts of Africa is, how do you define frontline workers? How do you define an at-risk population, right? How will these countries in Africa, including South Africa, make sure that we have one supply framework, not two for rich and poor, as we had with ARVs. And obviously there's some ethical and procedural principles that are contained in different ethical frameworks and documents being prepared by multiple research institutions. But the most important of that is that nothing for us without us, right? So if there's going to be a plan for a vaccine roadmap for South Africa, for the rest of Africa, communities have to get involved quite soon and early. And it's unfortunate that it's coinciding with the Christmas end of the year break. But if we don't, decisions are going to be taken in the next 2 to 3 weeks. In January, we're going to be told this is how it's going to happen, and communities wouldn't have had a say in how do we actually ration in the most fairest and most ethical way for the whole of Africa, and then obviously for South Africa, for our context too. Next slide, which is the final slide. So these are just some reading materials that you could use. If you want to understand why access will be a problem, I suggest you read the Oxfam and Amnesty International's press statement. It's very short. It's about how 9 out of 10 people in poor countries will not get the vaccine in 2021. If at all, we may get it in 2022 or 2023, right? So that's a problem. And then we've also written about the great COVID-19 vaccine heist. And so we call it a theft, and you can find those articles for free in the Daily Maverick. Next slide, please. And then these are our contact details. And like I said, you can contact myself or Althea, my colleague from Health Justice Initiative. Yeah, and please email us with any questions as well. Thank you very much, and I'm sorry I went over time.
No worries, Fatima. Thank you so much. That was really insightful, and I think a lot of thought-provoking things for us to consider. So as you were presenting, I was thinking around just the similarities or the potential similarities between this and some of the activism that most of us, I think, in this conversation have participated in terms of, the HIV, struggles and things like that. But I was also thinking around, so I jotted, a few things that just, that sat with me is around how, although we are towards the end of the year, and as you've said, December's ending in a few days, most of us have already, kind of like closed, shut down. It's been a hard year. Is the need to not disengage, is the need, to keep abreast in terms of what is happening, because come January, you'll be told, this is what has happened, and we as civil society, we as communities haven't engaged. So, the need for that ongoing engagement. I think the other is around, and as you were speaking, I was thinking around, how can we utilize existing mechanisms one, either to gain access to information, but also two, as a means for global advocacy. I think, although, this is very South Africa specific, I think the realities are, these issues, or what's happening in the global arena has a direct impact in terms of what happens in South Africa, in our little spaces, in our communities, and how can we then lobby our governments, how can we lobby even international bodies as a larger collective and not as individual organizations or individual countries. I think before I go on, I'm like, if there's any questions, any issues of clarity, please feel free to raise your hand, feel free to drop it in the chat. But I think also just a reminder, if everybody, because I know sometimes our devices have got names, if you could all just put your name and the organizations you're coming from. This is one for the attendance register, but also in January, you'll all be getting a certificate for attendance and participation, and would like to get your correct names. Are there any questions, thoughts? The arena is open.
Hi, sorry, there was a little bit of a signal problem. Thanks for the presentation. I think I got the gist almost towards the end, and it made me think that most people, when they look at the newspapers or on the radios or listen to the radio, they're automatically under the assumption that vaccine is going to automatically have the same roll out as the ARV, right? And this means that there is a lack of awareness, like you were saying, but also we need to manage that expectation, because they're not communicating how they're rolling out. They're communicating that it is there, it is in trial. So that is a gap, and that means we must manage people. I know we are, as civil society, we are doing communities matters, which means we are doing a survey that assesses behavior change and the impact of the COVID-19 on our community members. And we have seen drastic changes, and those very people who have lost their jobs, who have lost their loved ones, who have had some measure of impact, meaning that they had to change their diet or whatever the case may be. We need to then go back to the very same people come January now to explain that the government has made decisions on how much ration are we going to receive, and they've actually then made certain decisions that you are not aware of. And this is where we need to get people to be conscious, and also public participation, so that they can also manage themselves right now. So I think we need to go back and use the very same communities matters mobilizers on the ground to then communicate what is the most effective way for them to get this rollout, and what does it mean if they do not have the ration agreement that they see fit. So it's also what happens if they get something they don't want, and what is it they want.
Thank you so much, Palisa, for that. I see Nonhlanhla, you have your hand up.
So yeah, thanks. Thanks, Fatima, for the presentation. I think very much in line with what Palisa has just said. I think my take away from this, very much also being somebody that has served on a couple of community advisory boards where vaccines are concerned. I guess the worry that one has is the level of engagement that is still required with our communities with matters at hand. I mean, when we went on lockdown in March, we had not had enough time to engage our communities on what even COVID-19 is. And we had to find a new way of community engagement in a context where we can't hold workshops, we can't do community dialogues. And I guess the worry where one is located right now, as indicated, having been part and parcel of the advisory board, is our way forward in getting our communities educated, more so about their rights in accessing treatments, but also just general understanding of what does it mean to have taken a vaccine. And it's not necessarily only because this is the COVID-19 vaccine, but it's really vaccines in general, but more so this one in particular. So yeah, I think mine was just that you know what, there's a worry about the level of community education that's going to have to happen to make sure that everybody understands what this is all about, but two, making sure that we are all on the same page in understanding our rights and the concept of access, and being able to mobilize in our own different environments and communities so that everybody has access as best as possible. But I think largely the third part being the how we do it as civil society organizations, bearing in mind that all of this is happening at a period where right now people's focus is, yay, it's December, it's festive time, we want to be with our families. Really all the other messaging does not seem to be as important. So how do we still get in and actually meaningfully engage our communities at this point in time?
Thank you so much, Nonhlanhla. I see Thabo you had your hand up before, Mabalani. Thabo?
Thank you very much, Program Director. My name is Thabo Majuja from Show Me Your Number. Okay, mine is just, I think that it's a narrative speaking question, because I was checking the numbers, last night of infections in South Africa. It was around 866,000. And now recovery was at 752. And I think active cases around 80,000. Now, my question is, what would inform, us, trying to purchase this vaccine? The issue of 10%, how it's going to be allocated, I can understand that that debate. But my issue is that if you look at the numbers, we only have about 80,000 of the total population, people with active cases of, of corona. And now, because now every time when there's a report coming out, we are always told about this number, 800 and something. Here we are close to 1 million. Whereas we know very well that, actively it's only 80,000. Why should we now, cause, what do you call it, panic, panic out there that, hey, the numbers are big, but we know it's 80,000. Why should we do that? Because for me, it's like, we're misleading the nation. Why don't we just come out clear? And then secondly, I think it's in respect of allocation as to how it should be allocated. Look, my take will be that, the people at the cold face of the fight against corona, which are like, healthcare workers, those are the people that, I think we should first, look at and prioritize and say, this ones must get vaccines. Then maybe after that, then we'll look at the people with comorbidities and old people, you see. That's my take on that one. Thank you very much.
Thank you so much, Thabo. So maybe we can take Mabalani's hand and then we'll give Fatima an opportunity to respond.
Thank you, Diane. Mine is what is the proposed other action that we need to take in terms of advocating also on the back of the issues that we are crystallizing in terms of availability of vaccine, but in terms of social and behavior issues, because I see a skewed response that is mainly interested in the biomedical response, but the social and behavioral issues, which is what exacerbate the challenges that we have, there is not enough focus around it. So how can we ensure that we have a two-legged approach that results in what we want to achieve? Thank you.
Thank you so much, Mabalani. Fatima, can I hand over to you?
Yeah, sure. And thanks everybody for your patience and for listening. I know it was a long presentation. But in terms of, I think Diane's first reflection around, having been through this before and around access to information. So certainly what's happening in other countries is that access to information advocates have been filing access to information applications to at least get the details of the agreements between the drug companies and the research institutions on the vaccine trials. And that's how we were able to find out some, not all, pieces of information about the deal with AstraZeneca, etc. And in South Africa, we've decided that we're just going straight to government to ask them what's the plan, because a lot of the universities that have partnered with these drug companies have signed confidentiality agreements. So, they're not really, they're not disclosing or releasing a lot of information. So I do think advocacy around, particularly the companies who are doing trials here. I feel like it's a real injustice that the regulators and government in these institutions allowed this without securing access. So Palesa, I think you make some excellent points. And I think this is precisely why we're asking government to share information and to communicate better. The president having these addresses, every few weeks at night, only talking about non-pharmaceutical interventions and creating an expectation, like you said, that everybody's going to get a vaccine is a problem. And so I do think more pressure needs to be put on the Department of Health and the presidency to communicate, if not on an almost daily basis, on issues around testing and vaccine coverage. So one of the problems in South Africa is that we were having daily briefings on the lockdown rules, but then the briefing stopped and the Q&A sessions with journalists stopped when we needed it most. And so, we really need a detailed briefing on the vaccine plans for South Africa and access, because I think to be honest, I think like we're being treated as like little children who don't understand the issues and nobody gets to question. And I think the COVAX payment issue sort of, highlighted that government is doing a really bad job at communicating around the expectations for vaccine access and equity. And so that's certainly something that needs to be addressed, because I think it was the Thabo who said that people think that the numbers are going down and that the president is making a fuss about the beaches. And so behavior is not necessarily changing. And this is because a vaccine is coming, that's what people think. And I think that's the thing that we need to address as community, because it's not coming to us certainly for another 2 years at least. And then level of engagement from Nonchancellor around community preparation, I think also links to what Palesa said. I think government messaging is very poor in this. There's a lot of infographics and fact sheets and apps and podcasts about beaches and the curfews and the alcohol, but we're seeing very little, right, around this aspect, which is the thing that most people feel is actually going to help and work. And I think it's also important, if they get ahead of the curve on the messaging, to deal with the people who don't believe in a vaccine, are anti-vaxxers. And then Thabo's point around the, the reality of the prevalence of COVID, the active cases, the number of recoveries, the number of tests that have been carried out, the number of infections, the number of excess deaths that researchers are reporting on, which is not being reported in the COVID-related deaths, because a lot of stuff is still being reviewed and assessed. I think that would require a clinician, somebody like Francois Venter or Linda Gail Becker, to explain that better. But there is a real concern that there is massive underreporting. The biggest concern we have is that there may be active recoveries, but what it takes to recover in an already failing healthcare system, like in the Eastern Cape, is actually bringing this country to its knees. So if you add COVID to an already difficult public health care situation where there's staff who are getting very sick, staff who are dying prematurely, not enough hospital beds, not enough oxygen. I mean, we're getting reports about people dying in the parking lot of Eastern Cape health facilities. So the impact that even 80,000 recoveries or even a couple of million cases has on your health system is quite severe. And that's why I think we need to deal with it in a more urgent and serious way. The proposed action, Mamalani, I think you're absolutely right. This was just a presentation on vaccines, but the C19 coalition, there's a number of advocacy groups who have been calling. So what I think is 4 different things that you also need to call for. The one is better socioeconomic relief. We have a hunger crisis. It's going to get worse in December. And you saw the new restrictions. We have small businesses that are basically collapsing. We have people who have lost jobs, joblessness, unlikely to get their jobs back in the next 2 years. The health system is collapsing, particularly the public health system. But even the private healthcare sector is saying we don't have enough beds, we don't have enough staff. And then there's a real issue with testing. People can't easily get access to a test unless you can pull out 1,000 Rand from your pocket. Testing, integrated testing for TB, HIV, and COVID could be something that government could look at. What we call the NPIs, the non-pharmaceutical interventions, you know, I don't really often agree with the president, but he's right. We're not following social distancing. We're not doing the masking properly. We're not doing the hand washing. But I think that then is a question back to government to say, well, you know the things that can take us out of this pandemic, but where is the plan for informal settlements? Where is the plan for proper and decent sanitation and housing? And so COVID has exposed all of those issues to say, we can't just focus on the vaccine. We also need to focus on, well, why can't people wash their hands regularly? And why are people having to be cramped up in a public taxi? You know, so there's a lot of blaming, and I think there's a lot of racism as well in how we're measuring whether communities can actually adhere to these measures. So yeah, I totally agree with all the questions that have been raised.
Thank you, Fatima. I am mindful for time. So what I will do is I'll end the discussion here. But I think it's just to echo that, you know, I think although we having this conversation around vaccines, is that, you know, we still need to, you know, encourage, I mean, we still need to abide to the social distancing and all the other, you know, interventions that we know, you know, can work, that we know, you know, that we've been doing and that the government is emphasizing. So it's not to say that because we're having this conversation, then, you know, that aspect, you know, falls away. It's, you know, how do we do everything in how, you know, how do we have a dual approach, or, you know, however approaches we need to ensure that, one, people are safe, but also, you know, that people have got access to vaccines. And I think just to echo what Fatima has said is that, you know, this is the first engagement. This is not the last. So from this engagement, you know, today, thank you so much for your time, for your questions. What will happen next is I will be reaching out to everybody who has attended. And it's just to get feedback from you in terms of, you know, what this conversation means for your community, for the spaces that you're coming from. You know, there've been questions here around, you know, what does access look like? You know, so I'll be reaching out to each of you and asking you those questions. And then next year, what we are wanting to do is, you know, from your responses is to come up with a position paper or with a position statement around, you know, this is what, you know, as civil society organizations or as civil society in South Africa, what we would like to present. Then there will also be some fact sheets. So we are going to be developing fact sheets for this, and those fact sheets are things that you can then take into your communities as part of, you know, awareness, you know, building awareness. The African Alliance, you know, will then also be issuing out certificates for attendance and participation. But I think it's also like what Fatima has said, is just to keep an eye in terms of the different spaces where we're having these conversations, so that this conversation doesn't end here. And what we will do, you know, for those, you know, because we have all your contact details, is we will then, you know, send you information as we get it. I hope that's okay. I think just before we end, if we could all switch on our cameras so that we could take one picture. And also a reminder, if you haven't yet sent your name and especially the name as you'd like to appear on your certificate, please do so now before we end the session. But if we could all have our cameras on for a group photo, as we do at most sessions, it would be ideal. And a beautiful big smile.
Diane, can we also just ask people to keep their cameras on for a bit, because there are two screens, so I just need some time for that, please.
So we've all heard, so we can also keep our cameras on for a little bit. And I think once the photo is taken, we will be told the deed is done.
Yeah, just waiting for a few more cameras to switch on, please. Just a few more.
I think there might be people who don't want a photo, so I think we can also respect that.
Okay, no problem.
Now we're giving away our age.
Are we done with the photo?
Are we done, Chiwa?
We are not done, we are done.
No, it's the Monday.
Masawe,
we need to go to other meetings. Are we done?
Thank you so much. We are done now. Thank you very much.
We are done, so thank you so much. Please expect the presentation in the next day or two, and I'll be reaching out to everyone. Thank you so much.
All right.
Bye.
Thank you.
Bye.
Bye.
Bye, Diane. Thank you.
Bye. Bye.
Thank you so much. Bye.
Bye.
Thank you so
Thank
much.
you.
Bye.
I don't even remember how the Zoom of it.
We're done. Thank you so much. Thank you so much. Thank you everyone for your time and your participation.